And before we start, I wanted to give a special thank you to Sandra Brackert and Majin Kim, and also Annie Ashe for really doing the brunt of the work to really get this forum set up today. So you can all give them a round of applause. I also want to thank some of our industry friends from Eli Lilly and Johnson & Johnson who are here today. So if you have a chance to speak with them, that would be wonderful too. So I'm going to give a broad overview of sarcomas and leiomyosarcoma. As many of you, when you come to UCLA, a lot of people come here and you're not exactly sure what a sarcoma is. They're very rare tumors. One of the teachings I always give people is, what are the different types of cancers that are out there? So we all know all the common types of cancers, which are like breast, prostate, lung, colon, and other gastrointestinal cancers. Those are all the common types. Those are called carcinomas. In some way, those are cancers of the outside because they all essentially communicate with the external environment. For instance, the lungs through the airways, the breast through the milk ducts, and the GI tract, of course, communicates with the outside. There's blood cancers like leukemia and lymphoma, and they're brain cancers and skin cancers. And then the other frontier are connective tissue cancers. Connective tissue means muscle, fat, bone, and the like. And leiomyosarcoma, as you've all probably learned by now, means smooth muscle cancers. So there are different types of muscle. There's cardiac muscle, there's skeletal muscle, and smooth muscle, which are the three main types of muscle. And that's what we understand at this point. Cancers, as you know, start from our own body cells that genetic derangements make them grow uncontrollably. And so, as you can imagine, any different cell type in the body has the potential to turn into a cancer. And that's no different for leiomyosarcoma, which can start from various smooth muscle, we have smooth muscle throughout our body. In this example, for instance, the adipocytes, which are the normal fat cells, can potentially turn into liposarcoma. Osteocytes, which are bone cells, can turn into osteosarcoma. And here we have muscle cells, myoblasts, can turn into rhabdomyosarcoma, which is skeletal muscle. They don't have leiomyosarcoma in this cartoon, but smooth muscle exists throughout our body in the large blood vessels and small blood vessels. And in many leiomyosarcomas, you do see some vascular staining as well, or vascular and smooth muscle staining. So because we have connective tissue throughout the body, sarcomas can start essentially anywhere. And this is not meant for you to look at this whole thing and memorize any of this. This is just a broad idea of where the different types of sarcomas can start in the body. I don't know what color you call this. Dark pink, this is leiomyosarcoma. So you see in the abdomen, about a quarter of all of the abdominal tumors are leiomyosarcomas. In viscera organs, about 60% are leiomyosarcomas. But overall, in about 20% of sarcomas are leiomyosarcomas. We estimate there's about 15,000 new cases of sarcoma a year in the United States, but there's actually about 60 different subtypes, or there are people who call splitters to say there's probably a few hundred different subtypes of sarcoma. And Dr. Cohen and I were just talking that, we see a lot of sarcoma, and this number probably underestimates really the true incidence of sarcoma. And people are working to try to see if there can be a better and more accurate characterization of the number of cases we have a year in the United States. Because of the rarity and the diversity of these sarcomas, there are several challenges. One, to find treatment teams that have enough expertise dealing with these malignancies, know-how, and also the whole biologic challenge. What are the drivers of these cancers, and how can we find medications to target these types of cancers? So UCLA and actually at large academic centers throughout the country have sarcoma teams. And this is the UCLA Sarcoma program. And several of these physicians are here today, and Sandra. And basically, the foundation of treatment for leiomyosarcomas on any sarcoma is that you should have a multidisciplinary team. You need a surgeon, a medical oncologist, a radiation oncologist. You need psychosocial support, nutritional support, and pathologists and radiologists who are familiar with dealing with these diseases. So in terms of the diagnosis, so because of the rarity and the diversity of these tumors, it's very important to be clear about the diagnosis. And so that's where everything starts, and that's where, when we guide you in terms of what types of treatments we would recommend, the diagnosis is really probably the most important step. And you really want to have your tumor reviewed by a pathologist who sees a lot of cases, because I'll show you in a little while, there is diversity even in what leiomyosarcoma looks like under the microscope. So pathologic review is very important. What does pathologic review mean? It means looking at the shapes of these tumors. It's the morphology. It means doing specific types of stains, coloring the tumors. That's really looking for particular proteins which really help the pathologist make the diagnosis of a sarcoma and leiomyosarcoma. And also the grading. The grading is important for many types of sarcomas. Grading gives us an idea of the clinical behavior. Is something that behave more aggressively, less aggressively? And I'll make one comment. Leiomyosarcoma is a funny sarcoma in that low-grade leiomyosarcomas do have the propensity they can spread to other areas of the body, and that doesn't hold for all sarcomas. And so grading is still something that is undergoing fine-tuning, and people are trying to find better and better ways to predict, is your tumor going to spread? What is the chance it's going to spread? Because that's a real question for many people, and also for whether we're going to guide you to do chemotherapy, radiation therapy, and so on. So this is the slide about histology. Under the microscope, the pathologists look at the appearance, and there are several different terms. Maybe some of you have seen some of these terms underneath in your pathology reports. Oops. And essentially, they are descriptive terms of the shapes of the cells that the pathologists see. This is a sarcoma, and you can see it looks pink and purple, and this is called an H&E stain. This is one of the most common and the basic stains that are done to look at a tumor to help make a diagnosis. Leiomyosarcoma, people believe, originates from smooth muscle cells. I say believe because it's a very hard thing to prove, and often the specific stains that they do look for proteins that are seen in smooth muscle. Smooth muscle, SMA stands for smooth muscle actin, desmin, and caldesmon are some of the more common stains that people do for leiomyosarcomas. These are 4 cases of leiomyosarcoma, and you can see this one looks more monotonous. This one, there's this what's called palisading in the center. This one is this is called pleomorphism, that there's many morphologies, and I'm not even sure what this one is called. But the idea here is that just the same tumor can have just a diversity of appearances under the microscope. So as you can imagine, this can be very difficult for people who are not familiar with these tumors to give this a name. So you really need, this is where experience, a trained eye really matters, because this is what people are looking at under the microscope to give you an answer. And a lot of times when you come to us, we harp on, can we get your pathology slides from the hospital you were treated at before? And this is so important to have this done. And anytime you call Majine, I always tell Majine's always telling you, get your slides. And that's what we tell her to do, is because this is such an important step. In terms of grading, grading, the basic things are whether it's high grade or low grade. And these are some of the features that we look at to try to characterize things by whether they're high grade or low grade. We're not going to go through this too much in detail, but that's a general overview. And so these are several different types of sarcomas, and the different types of grades that they present with. But leiomyosarcoma, you see, can present with low, intermediate, or high grade. And that's, yeah. Also, leiomyosarcoma, it's not, it's, when I said before, are there really 60 or 80 types of sarcoma or a few hundred? Because for leiomyosarcoma comes in different flavors as well. There's the leiomyosarcoma of the extremities, of the abdomen and retroperitoneum, and a lot of there's also vascular leiomyosarcomas that start from the inferior vena cava, which is one of the large blood vessels in the body, and also the large veins of the abdomen and pelvis can be the site of origin of a leiomyosarcoma. There's cutaneous or skin leiomyosarcomas. These generally behave in a much more indolent or slow-growing manner, and they don't have the same propensity to spread to other parts of the body, such as compared to deep-seated leiomyosarcomas that are deep in the muscles or in the abdomen and pelvis. There's such a thing as leiomyosarcoma of people who are immunocompromised, people who have had organ transplants or an immunosuppression, or have particular immunologic disorders that lead to immunosuppression. And lastly, I put this in a different category as leiomyosarcoma of bone. It's a very extremely rare entity, but it is an entity that is acknowledged, and it has a kind of a different behavior than the other leiomyosarcomas, but it can be very aggressive as well. Staging, we don't like to talk about staging because these types of staging systems are built for many types of malignancies, and there's something called N, which means T really stands for how big the tumor is. N is nodal, whether the tumor is involved in nodes, but sarcomas by and large rarely involve lymph nodes, so these systems are not really meant for sarcomas. We're very simplistic. We say, is it in one place or is it in many places? And that's really, when I tell people that, you still come and you still ask about the stage, but it's not as important. But the grading and size and location are probably the most important things. Okay. Biology, what do we know? The answer is not very much. Under the mic, if you look at the genes for leiomyosarcoma, there's it's very deranged, and essentially that's one way of saying that there's a lot of heterogeneity, and we are not able to group them in a way that makes sense to us, in a way that we can tell you whether a drug would work well for a particular type of genetic abnormality that we find. And with regard to many sarcomas, about a third of sarcomas have things called translocations. It's where the genes of your body break apart and rejoin in unnatural ways. And but leiomyosarcomas generally do not have translocations. Yes, if you look hard enough, there's a few anecdotes of cases of leiomyosarcomas having translocations, but by and large, compared to other sarcomas, it's not very prevalent. This is one study looked at a group of leiomyosarcomas and tried to identify mutations found in them, and these are particular genes, and this is the frequency of the mutations. And by and large, recurrent mutations are not very common in leiomyosarcomas, and the ones that are common are not ones that we have good targeted agents for. And some of this lumps general leiomyosarcoma and uterine leiomyosarcoma. There's a debate out there whether or not uterine leiomyosarcoma, which is probably the most common after the generic leiomyosarcomas, whether they're truly similar entities or they're slightly separate entities. And maybe Dr. Cohen will talk a little bit more about that in his talk. So that's an ongoing area of investigation. For systemic agents, I'll touch on this a bit. There's several different drugs that we use. These are all the doxorubicin everybody's heard of, ifosfamide. You can use gemcitabine by itself. Dacarbazine, DTIC is the other name. Pazopanib, the trade name is Votrient, Trabectedin or Yondelis. And these are, both Votrient and Yondelis are more recently approved medicines. And the combinations are the common AIM, doxorubicin, ifosfamide, Gemtax, and more recently, doxorubicin and olaratumab, the trade name Lartruvo, was just recently approved for soft tissue sarcomas or advanced soft tissue sarcomas. And I'm going to touch on a few trials. It's always been a conundrum whether you should give doxorubicin and ifosfamide together or whether you can give them sequentially. And it actually took our field probably about 40 years to come up with the answer to this. And this was a study that was recently published in 2014. And the study was basically this. You take 50% of patients you give doxorubicin alone to, and 50% you give doxorubicin and ifosfamide to. That's what the stratification here says. And basically, it doesn't really make it. This is just a slide that shows that you have overlap of the lines, so people do just about the same, whether you get doxorubicin or you get doxorubicin plus ifosfamide. You do have one thing that is improved with doxorubicin and ifosfamide is something called the response. So in cases where you want to have a good response, doxorubicin and ifosfamide is the best at giving a response. So this is about 27%. The response to doxorubicin by a single agent is about half of that, and it ranges probably from 7 or 8 to about 15%, depending on which clinical trial you look at. One other thing I wanted to point out, in this trial, all the people who were in doxorubicin by itself, after they progressed, several people got, let me see if I have the little, about 50% of them ended up getting ifosfamide. So it's felt that that is the reason why giving them sequentially is just about the same as giving them together. And this is a very important thing for you because giving doxorubicin and ifosfamide together is very toxic. It's very hard to do. So generally when you come, I only give it to younger and fitter patients who don't have a lot of other medical conditions. So when I say it's okay to use doxorubicin by itself, then there's good data to say that that's the case. Okay, all right. More recently, there was a trial for this medication called Yondelis or Trabectedin, which has been around for more than a decade now. It's already been approved in Europe and Southeast Asia previously. But the American FDA did not approve this medicine until more recently, probably about a year or so ago. And this trial was for leiomyosarcoma and liposarcoma, and patients either got trabectedin or dacarbazine. And there was an improvement in what's called the progression-free survival, how long you go before the disease grows again. And based on that, the FDA approved this medicine. I split it up between leiomyosarcoma on the right, or my right, and liposarcoma on the left. The response rate is small, and in the single digits essentially, but it does slow down the disease. So if you were to ask me how do you characterize the benefit of Yondelis, it slows down the growth of these cancers. This is I stole these slides, and so it does have a pharmaceutical on there. But Dr. Chmielowski is on this study. This is a study of that recently got Lartruvo approved, and in this trial, what is Lartruvo? I should tell you, or olaratumab is the generic name. There's this is the cell. This is the cell surface I'm pointing to here. And this is inside the cell, this is outside the cell. There are these things called platelet-derived growth factor receptor. It sits on the surface of a cell, and it binds different proteins, and what it does is actually leads to growth of the cells. And somebody made an antibody to this. An antibody is another protein that can block the signaling and prevent the growth process. And so they said, well, how do we know that works? So the way you know that works is you give half the patients doxorubicin here, and the other half you give them doxorubicin plus the new antibody itself. And after in this trial, more and more people are asking about this medicine now. After you can only receive about 8 rounds of doxorubicin, and after that you get the antibody by itself. And so this did improve progression-free survival. How long goes before your disease progresses. But more importantly, what was seen was that there was this nearly 1-year improvement in survival. And so this is the first trial in sarcoma and soft tissue sarcoma ever to show that the addition of a drug can help to doxorubicin can improve survival. And by and large, in all of cancer, to have any medicine show an improvement in survival is a very hard thing to do. And this is because of this, the FDA approved this medicine, and so it is available now. This has been approved as an accelerated approval, and that's rarely done for a phase 2 trial. This was not a phase 3 trial. And the reason was because the data was so convincing that they can't not approve it. And so, but when the FDA approves things based on phase 2 trials, they usually ask for a phase 3 trial. That's ongoing, and I think it's almost finished now. But it will take probably another year to 18 months to get a readout for the public. That's all I have. I'm not going to go into more. Dr. Chmielowski will talk about some clinical trials and the use of immunotherapy in this disease. So those questions you can hold for him. I think what we've decided to do is after each speaker to have 3 or 4 questions, so everybody gets a chance. We were going to have a open forum discussion, but I'm not sure if that's going to happen because some people might have to leave. So after each speaker, 3 to 4 questions. Yeah.
Can you describe pleomorphic?
Pleomorphic is the term. Pleo just means many morphologies. So under the microscope, there's many different shapes that are seen under the microscope. Yeah. Mr. Lewis.
Pleomorphic tends to be aggressive.
Tends to be aggressive.
Yeah.
Mr. Lewis.
Yeah, on the listing of the different types of LRS, uterine cancer had 2 asterisks on it. And I was curious as to what that means.
The asterisk. I didn't address it directly, but it is the question is uterine leiomyosarcoma really the same as leiomyosarcoma from the extremities or of the inferior of the blood vessels? So that's something people are trying to work out, and Dr. Cohen will hopefully try to answer that a little bit more in detail too.
I would encourage you to ask questions. Now's the time to do it, right? I mean, if you have any, don't be shy. And also I think is in thinking about this, these support groups have a lot. You're more powerful than you realize, and that your voice is not insignificant. Ask the questions that you don't understand, and we'd be happy to tell you. And don't forget that you guys have a voice in this.
Yes, could you briefly describe genomic testing?
Yeah. So genomic testing is basically you need, how it happens is this. If you have a tumor, they can take the tumor cells that are, so maybe you might not all know this, but when you have a surgery, your tumor is actually frozen in a freezer somewhere. People can go back to that freezer, cut out some of the tumor cells, break them apart, and isolate the genes, and then we can do something, a procedure called PCR that looks for what types of mutations are actually in your tumor. So when you see those mutations, they're unique to your tumor. But the thing you have to realize is if you have a mutation, it does not mean it is what is called a driver mutation. That means it leads to growth. Some of them can be passenger mutations. That means they are there, but they don't really have a meaningful effect. It's just because cancer, you have deranged genes, so you have some DNA damage. So you really have to have, so we can just send it off. There's one called Foundation Medicine. There's several other ones around as well. But you really need someone who can interpret that sequencing and to guide you whether or not there's an appropriate drug to use, and whatever drugs are out there, whether those drugs are actually safe for you to use, because a lot of the information from the sequencing, you want to use early stage drugs that are not FDA approved as yet, and so you really need somebody who knows exactly what's going on with those drugs.
I mean, I think the way to think of it is it'll give some additional ideas of what drugs potentially may work in the tumor. It's not that it will work,
Yeah.
but it gives some additional ideas that, I mean, depending on the situation.
Yeah, and when we're running out of the list I gave you, once that list is being exhausted, this is what we should be looking for. Annie? Yeah.
Does the initial genomic testing of the first tumor, does it allow for indicators of potential reoccurrence? If there is a reoccurrence, is there another genomic testing that's done?
Yeah. So I'm going to split up your question. So the first question is, if you do genomic testing, does that tell you whether it increases your risk of recurrence? No, we have no idea based on the genetics of your particular tumor whether you will have a recurrence or not. That's research. That's all research.
Well, that's also driven by clinical factors. I mean, you can have a 20 centimeter has a certain gene pattern. I mean, obviously 20 centimeters has a higher chance of coming back. They don't know that, right?
Yeah.
So that's
It's the clinical factors still trump the genetics in terms of recurrence risk. And the other question was really it's this. So when you're diagnosed versus years later when you have a recurrence, if you do genetic sequencing, are those things similar? In many cases, they have similarities, but they also are differences. So we don't always like to test the earlier tumor because it does undergo it changes over time. So the later tumors are probably the better ones to sequence. Okay. Over at the back.
In those testing, are new medications tested on the sample of the biopsy?
We'll talk about that. It's interesting. Arun knows him. It's one of my friends from college. His father was a very Trump-esque guy, a very wealthy family in New York, and his mother got cancer. And he had his mother's tumors sequenced and this, that, other thing. Some Nobel laureates review it, and everybody had ideas about what would work on his mother's tumor, right? It's a list of like 20 drugs. And of course, the only way you find out is to test in her, unless you have a model to test them in. And I'll talk about that. I think it's important to realize that it's not necessarily the answer, they're ideas. And whether it'll work or not is currently determined by the patient. So, I mean, that's an excellent point. And one of the things that I will touch